too. So our next speaker, Jen Schwartz, is coming to us from New York City. That's a small city there, and I won't give her any more dues just yet. I have some stories I'll tell about her, but I don't want to make her nervous. So we'll welcome Jen. She's going to give us a journey through concussion. So that's all you do.
Good afternoon. So I get to close up shop today, which is pretty awesome. You guys are still vertical while I'm up here. This is awesome. So every single lecturer today has hit on some amazing topics. I kind of hope to bring them all home. It was pretty great for me because I'm actually hearing them all for the first time like y'all. So hopefully we get to wrap it up and get you guys in the lab for later today. All right. So Tim told me to start with a song, so I thought this one was appropriate. I don't think it's as good as the public floor lecture one earlier. That was pretty good. Thank you for having me. I thank you for your time and attention in advance. So this is pretty exciting for me. This is what I love to do. I love to talk about concussions to healthcare professionals across the whole spectrum, whole healthcare continuum. But it's awesome that I get to be in front of y'all today, my people, doctors of physical therapy. Okay? So we have this profound responsibility as clinicians to our patients, to our colleagues, to ourselves. And I think Dr. Benz hit it, on the head, literally, no pun intended, earlier today. And really being able to be connected to yourself as a clinician can really make you connected to your patient that much better. And I hope that this carries over into this talk as well. So I like to get a little artsy sometimes, and I really hope that we start to build some bridges. I think we say that, I treat ortho, I treat neuro, so on and so forth across the continuum. And I hope to really start building these bridges, because with concussion, you really can't treat in a silo here. You have to work in a team. So I really like this quote. Tell me and I forget, teach me and I remember, involve me and I learn. Does anybody have a smartphone in here today? Raise your hand. Perfect. So let's get social. All right? If you're on Twitter, use the hashtag Manipalooza. @EIMteam is the Twitter handle, and I'm at DPT to go. So the only thing I say, take pictures, do what you want, because folks will then actually follow that hashtag who aren't here from all over the world. I know we have folks from New York, and Japan, and California, but folks can now access you all around the world just from this hashtag, so it's pretty neat. If you do take a picture, just make sure make note of it. All right. So, this is not a slide about the Denver weather here, although it's pretty sunny today. Concussions are like snowflakes, okay? If you've seen one concussion, you've seen one concussion, okay? Every single concussion is going to be different, all right? And that's really true across the whole TBI spectrum. There seems to be this great divide, though, in the media that our perceived competence in concussion treatment, identification, and management is up here. But factually, there is no evidence-based medicine for concussion. Bottom line, period, end of story. Okay? So I think once you kind of let that set in and think about it, you can kind of look at the concussion spectrum a little bit different. All right, just facts. We'll go through this rapid fire. Concussions expand across the whole entire spectrum, from musculoskeletal to ortho to neurological, cognitive and psychological domains. Okay? okay? There's no one test that can identify concussion. Please remember that. There's no one test, no matter what you hear in the media, that can identify concussion. There are over 43 working definitions of concussion. One of them is evidence-based. Okay? We don't define concussion neurologically. We don't understand the natural history of concussion. We have little, if any, data on neurobiological recovery following concussion. And the medical and neurological community have enabled a culture that did not address concussion until recently. So in March of 2013, the American Academy of Neurology updated their 1997 guidelines on evaluation of concussion, of sports concussion, and they had a major change, and that was actually the removal of return to play recommendations. Since we're in the scientific infancy of concussion, and it's really an infancy, okay? We're not the moon yet, it's an infancy. It's a public health epidemic, and I don't think people realize that. There are over 2.2 million emergency department visits just for TBI and TBI alone concussion. The CDC estimates about 3.8 million, but about 25% of folks don't actually seek medical care who get concussion. So I think all of this data, similar to what we've been hearing all day, is skewed. Some things that people think that need to happen with concussion. You don't need to lose consciousness. You don't need to hit your head. You can't have a coup-contra-coup injury, like in a whiplash model. You can have a subconcussive blow. And subconcussive blows, just pay attention to those words, because that's going to be kind of the future of concussion conversation and research. Okay? Subconcussive blows are the body checks, are like cumulative blows to the body over time. It's kind of like if you hit your, you fall on your butt, you hit your tailbone, you get a headache. Well, I'm speaking to biomechanical experts here. You get a headache often because that reverberation up. Okay? In the last 20 years alone, there has not been one phase 3 clinical trial to have gone through for a magic drug for concussion, okay, for TBI concussion. So think about that. Over 20 years, folks have been working so hard, PhDs, scientists, physicians, to look to see if there's a magic drug, a pill for the pharmaceutical intervention of TBI, and there's not been one. So concussion is a clinical diagnosis solely, okay? And we're in a room full of clinicians. Most concussions spontaneously recover over 2 to 4 weeks, okay? About 80%. Again, this data can be skewed, because I think a lot of folks aren't reporting. But about 80% in the literature is what's pretty prevalent out there, which leaves about 20% of folks that develop something called Post-Concussion Syndrome. That's usually after 30 days, and then it's a battery of testing to confirm that diagnosis. And those are all clinical tests. So what's neat, what a lot of folks don't know about, and I'm actually going to go into in a couple slides later, is that what's happening now with concussion research. So the NCAA and DOD, the Department of Defense, have just formed a grant alliance, started last year. So it's a $30 million grant from the government to look at our Division 1, 2, and 3 athletes. There are actually more Division 2 and 3 athletes in Division 1, just FYI. There are 460,000 NCAA athletes, and over 1,100 NCAA schools that are participating. Well, what does an NCAA athlete and a service member have in common? Well, about 80% of those concussions that are happening in the service, for our service members, are men and women, and for our athletes, biomechanically they're similar. 80% of all concussions. Remember that 15% of service member concussions are from glass. So, these are some common concussion symptoms. Super simple, colorful on a slide. Doesn't seem so hard, right? Well, CDC data, we've been talking about a lot of sport concussions lately, but CDC data says that 35% of TBIs are coming from falls. Well, I know you guys had the privilege to work with Julie Whitman earlier today, and Dr. Whitman worked with geriatrics a lot. Well, in 2030, 22% of our population is going to be 65 and older. So think about that. We're making people more active because we're physical therapists. We're making them move. We're getting going. But 35% of TBIs are coming from falls. So it's really not talked about. And this is so important because this is not a sport concussion lecture. This is a concussion lecture. So you're going to see folks that are now demented when they're in the geriatric stage. 65-year-old, 70-year-old patient that you might be treating 2-3 times a week, and you might know them throughout the last couple of years from treating them on and off. But they're not demented when they're coming in. You have to be able to screen for concussion. TBI numbers from the DOD, 82.4% of TBIs are concussion. Okay, this is huge. These are huge numbers. So, what is this DOD Grand Alliance with the NCAA? This is essentially going to be like the Framingham study of concussion. Okay, just started last year. These are the schools that are involved. Michigan is actually taking lead, and folks are looking at all domains, from imaging to drugs to you name it, it's being done. Rehab component. Started in April 2014. They had a meeting about clinical protocols. May 29th of 2014, they actually met at the White House. It was actually a big gala, big event. August 2014, the clinical protocol started, and then in November 2014, there was an educational Grand Alliance to start to push this forward. So they're going to hopefully have over 30,000 athletes enrolled in this, and it's going to be the Framingham study of concussion. But it just started. So we're really at the infancy of what we even know about concussion. So I did some video to add some texture. Everyone likes video? You guys just had lunch, so I'll give you guys something to watch.
When we got this former NFL player's brain, we saw something very striking.
It's an alarming report linking football and dementia.
Now I'm starting to see players who are younger than me who are having neurological issues, and these players are calling me.
In fact, many ex-players have problems. Girls having higher rates of concussions than boys.
You're talking to the athletes about donating their brain.
5 years of headaches and depression and short-term memory problems as we go back to work.
Are you advocating, Mr. Macy, that people not play football?
It's not just the American football problem.
More and more studies are coming out saying human-dependent headers are damaging the brain. When you scan a soccer player's brain, it no longer looks like the average person.
PB hockey today is not the PB hockey we played when we were kids.
The level of violence would give a reasonable person pause.
Rugby aficionados say you can't compare rugby with NFL. Research done shows that there's a slightly higher incidence of concussion in rugby than there is in American football.
This is a public health issue. Yes, there's contaminated at professional level. But what if similar things are happening for kids? Personally, if I had a 6-year-old on there playing football, I would be freaked out, and I think rightly so. Because you're playing Russian roulette with their future.
Has anyone seen that movie in this? Anybody? Yeah? Only a couple. Alright, so I highly recommend it. Okay? I'm a non-disclosure girl, but this was a Sports Illustrated 2012 Movie of the Year. It's called Head Games. It's actually written by a post-concussive survivor. His name is Chris Nowinski. Chris Nowinski is the founder of the Sports Legacy Institute. He's also the Harvard football captain. Okay? He was like, I graduated. Do I go to MBA? Got my MBA. Harvard football captain. Probably go wherever I wanted. Or do I go have a little fun? And he went to go have a little fun. So he actually became one of the top wrestlers for the WWE. And in 3 months, he was on Monday Night Raw, and he actually sustained a pretty hefty concussion where he doesn't remember. And actually wrote a book because for 5 years he had grueling headaches. was seeing every specialist under the sun, and actually wrote a New York Times bestseller called Head Games, which got translated into this movie. So if you haven't seen it, I highly recommend it. It's good for patient education and yourself. So who treats the concussion patient? What do we think? Go ahead. Everybody. Let's get more specific. That was sensitive. Let's break it all.
Athletic trainers.
ATCs? Yep. Anybody else? I hope physical therapists? Yep. Neuropsychologists? Great. Neurologists? PM&R? Pediatricians? It's anybody. It's not about if you treat concussion patients, it's going to be when you treat a concussion patient. Okay? Number one, who do we think acute concussion, who should we send? What kind of clinician should we send them to? Physician, what kind of physician? Neurologist. Okay, so here's something for you. This is the first academic year in which there's formal training for TBI concussion in the neurology residency. Okay, first year. So it's taking place under behavioral neurology, and it springs on the work from the advocacy of the sports neurology section of the AAN. You're doing great work. There's a lot to do. Okay, so if that doesn't put some kind of context into this, I'm not sure what does. We're all on the ground level here, and we all have to work together. This isn't about a he said, she said thing. It's about we need to sit down at the table and have this conversation as colleagues, as clinicians. So I'm really interested in healthcare and teams. Okay, I was an athlete growing up, coached in college, and I did my residency at New York University in 2010. We were the first 6, kind of a cool lot. And what I learned, really kind of crossing all spectrums of healthcare, from the OR to shadowing physician to working with other PTs, board certified ortho in sports. I was like, okay, I kind of see how this works, started putting the dots together. Also, my mom's a social worker, she'll get an appreciation for that shout out. So, I also went into the private sector. I think I broke her heart, but I think she got over it already. So, so we went back to this concept of healthcare and teams. This completely comes from Dr. Lorelei Lingard. She gave the opening plenary at the International Conference of Residency Education last fall. She's actually a rhetorician. She's from Canada. So what does that mean? So she studied language for 15 years amongst physicians. That must have been grueling. Okay, but she did this great opening plenary, and she's actually done some TEDx lectures. And so she's developed this concept that she's really refined, and it's collective competence in healthcare. Okay? And she defines competence as being a quality that individuals possess, a state to be achieved, context-free, and untied to time and space. But she discovered one thing, that competent individuals can form an incompetent team. I see some heads nodding. Yeah, probably all been there. Okay, that one rogue colleague. You know, I think of it like you can have a great point guard, you can have a great team. So I like to think of the Bulls. I'm an 80s kid, so I grew up watching in Chicago. And you have Michael Jordan. Well, you couldn't have all of those championships without Scottie Pippen at all. Okay? So we know that individual competence doesn't amount to good health care. Think about that for a second. We're sending people into this maze of disconnected care episodes. So everyone's becoming a specialist these days. And that's not a bad thing. But I like to say to my students, becoming a specialist doesn't make you special. It makes you specialized. But just because you're looking for one thing doesn't mean that you're able to screen for all. And I think we forget that sometimes. Okay? With these patients, they have so many symptoms that cross all deficits. You have to become a good screener. You have to look for the deficits. You know, they can come in with a headache, which you can't just treat the headache. They're having ocular vestibular issues. Okay? So, get excited for a little bit. I actually got really excited. Dr. Flynn talked about, there was a demise and it was B.B. King. I actually thought he was going to be talking about my slide here. So, I get a little excited when I talk about evidence-based medicine. So, I know. It's exciting. So, this tripartite mission here was coined by David Sackett. I actually don't know if you know, but David Sackett actually passed away 3 days ago. So this is actually pretty profound to actually talk about evidence-based medicine and have him in the news recently. So there's three parts of the stool here that hold everything up, hold us accountable. And I think we're really talking about the peer-reviewed literature a little too much sometimes. You know, I want you to think back to when you signed up for PT school or medical school. And you got that blue book. I don't know if they're still using blue books now. I think like fancy with an iPhone or things like that, but I had a blue book. And one of the questions was, why do you want to become a physical therapist? I can guarantee most of us in this room said because we want to help people. Well, if you think about that, this is kind of taking some of that away what's being delivered in some schools. So we have to remember that the clinical expertise and the patient values are so important. I can tell a patient, a migrant or a patient to rub some mayonnaise on their forehead, but if they don't believe in it, it doesn't matter what the literature says. The patient value has to believe in the procedure, in the intervention. So let's talk PBM. So in 1946, this was evidence-based medicine. No, this is not Dr. Stone's pelvic floor slide. This is my slide here. So this was probably heading for those of you who can't see, it says during menstruations, do and do moderately. Now I know we have a lot of women in this room, so can you imagine if doctor, lawyer, teacher, mom, and you were told not to do things because you're menstruating. So this was probably hanging up in 1946 next to have you smoke your Camel a day, right? But this is what we had back then, all right? And that's what we did, and that's what we pushed, that's what we knew. But when you know better, you do better. So in 1968, this was a little bit more pertinent to this crowd, best evidence-based practice for low back pain. So the most effective treatment for the patient with a recruited disc is to rest in bed until the pain subsides. And you and I both know what happens when that happens. If we had our patients that we would not have jobs anymore. So I think in medicine, when we don't know what to do with somebody, we tell them to rest, right? So it's 2015. Can anyone tell me what the most prescribed intervention for concussion is? So this notion of cognitive rest is not intuitive. Physical rest people kind of get, but then, well, when do you get up, right? So a lot of the recommendations are rest until symptoms resolve. Well, heck, we have a lot of people in bed for like 6 months, a year, and we already know the data. You lose 10% of your muscle mass for 2 days of bed rest. Let's not even go through the other symptoms. Just contemplate what that does to you. So we're telling people to rest with concussion, but we're not giving them any other specific interventions. Okay. Oh, so we go back to that. So to go back to rest, we also have to think there's been some new literature that just came out a couple weeks ago that is actually becoming more of a number needed to harm than a number needed to treat. Okay, you have to think that we're supposed to be doctors of physical therapy. We're physical therapists. We're supposed to make you feel better. But if folks are prescribing rest and solely rest for concussion, we're actually doing more harm than good because we're not getting any more feedback and goals. And we're like the short-term, long-term goal, like kings and queens of medicine here. So we know that there's no evidence-based medicine. So in 2008, a ton of clinicians met up in Zurich, picked a good place. And they kind of had this roundtable discussion about, well, what do we do with these people, these concussion patients? So this is what came out in 2014 from Clinical Journal of Sports Medicine. Their guidelines include a lack of diagnostic specificity, management strategies that are not evidence-based, and rehabilitation goals that are not attainable. Given these problems, the Zurich guidelines cannot be endorsed. Okay? But there's a problem. Clinicians are not versed in concussion, so they're going through these guidelines, and they're only, clinicians not versed in this syndrome simply follow the guidelines. Well, they just had new guidelines come out in 2012, we're going to have another meeting in 2016. But what's happening is that the 2008 guidelines, if folks aren't even up to the 2012 guidelines, forget that, knowledge translation. But said, for concussion patients, 2008 said, have the patient rest until symptoms resolve. Well, I mean, 1968, we already know what happens with back pain. So we're just kind of hitting the cusp of what's happening here with concussion. So Ben Utep is the American Academy of Neurology public speaker for concussion. He's a post-concussive survivor. He actually is a 2007 Colt, Indianapolis Colt Super Bowl winner. And he actually can't remember being in his best friend's wedding as his best man. So I think he's a great public speaker for the AAN. And it said, It took me losing my mind to care about my mind. So let's talk a little bit about what is concussion.
Injury, but there's nothing mild about it. It's only mild compared to severe brain injury where somebody's in a hospital bed with tubes and everything for days or months. The brain is elastic, it's like a gel mold, and it wiggles around. In a concussion, the brain changes shape very quickly. The really sensitive area of the brain is the white area, where all these nerve fibers travel from one part of your brain to another, allowing your brain to communicate. In a concussion, these axons get quickly stretched, and that causes injury in a very unique way. If I kind of make a cylinder and I pull it apart, it just gets thinner and thinner. The same material, if I apply this very dynamic stretch, is how fast I stretched it, and it broke. And that rapid stretch doesn't break these nerve fibers, but can damage parts of those nerve fibers. So they're like a garden hose, and inside are railroad tracks called microtubules that transport material back and forth throughout the axon. And if you break the railroad tracks, all transport stops. It's like the train car just fall off the tracks there, and everything pile up. For example, these very sticky, glommy cow proteins, and over even more time, the rest break because of the chemical destruction of the microtubules. If you disconnect these axons, they're gone forever. You can function without quite a few axons at a certain point, but you're at a disadvantage.
So let's talk stigmas. So a lot of these stigmas have been perpetuated by legal law literature. Okay? There's been really no poor scientific data from the medical community regarding concussion. So a lot of the stigmas associated with post-concussion syndrome and concussion are actually psychological, malingering, just negative connotations with concussion, post-concussion syndrome. But if you kind of think about the course of medical history and how medicine has kind of progressed throughout time, when we don't know what something is, we automatically assume the patient's crazy. Think about it. So if you had syphilis 100 years ago, you were actually a crazy patient. But then we got a diagnosis for syphilis and penicillin, and then you just had DPT. You weren't crazy. Congratulations. Go see Dr. Stone to help you out. All right. Same thing with B12 deficiency and thyroid deficiency. You were actually considered crazy until there was a diagnosis. So until we have a diagnosis for things for patients in medicine, we send them to the psych side. So we'll focus here briefly on TBI classification. I'm not going to spend too much time here to keep it moving, but if you just look at that highlighted part right there, all right, the heterogeneity of TBI in general is ridiculous. But if we just look at the MTBI, the mild traumatic brain injury component, that's ridiculous too. I mean, that in itself, the heterogeneity of just MTBI, if we're talking solely loss of consciousness, 1 minute or 29 minutes is still the same diagnosis. So classification. So that's a big difference. If you're unconscious for 1 minute or 29 or not at all, you're still an MTBI. Okay? So we can do better. So World Neurosurgery published last year. I could have done a backflip if I had the abilities, I would have. They're recommending, and I really hope that this translates into better clinical research for concussion. In terms of concussion and mild traumatic brain injury should not be used interchangeably. I can't say that enough. I really believe in that, and that might be my own personal bias, but I think we're going to get somewhere once we get better definitions of things. There are over 43 working definitions for concussion. Think about how hard research is for that. So we have these dynamic histories, and we are hopefully kind of getting back into connecting to our emotional intelligence and connecting to our patients and things like that, and that Dr. Benz was talking about earlier. But again, snowflakes. So taking history on these patients is crazy sometimes. It actually is. You're looking at the patient looking at you, and some people are like, what is going on? Okay, it's like literally 52 card pickup. So I swiped this totally from Dr. Grant Iverson. He's a neuropsychologist from Harvard Med. I just took a class with him at MGH. It was fantastic. I think I was the only PT in that class, unfortunately. But he really talks about the biopsychosocial model for poor outcome with concussion. And I think that's really important. Now that biopsychosocial thing is kind of like the new sexy word we're all talking about, but do we really know what it is? I think people are throwing it around. He talks about the pre-injury factors of concussion. So now we have to remember that this patient in front of us, this concussion patient, is a person, and they have a dynamic nature behind them that comes with a story behind them. Okay? So people's cognitive abilities, people's emotional intelligence, people's abilities to cope, financial situations, job situations, social, all amounts to who we are. He did a great job, and I'll leave that slide to him. So we have some of these symptoms. They're a little scattered sometimes they're a little bit more streamlined. These are great things that we can treat as physical therapists. Now, I, in particular, highlighted the depression component. That is not our scope of practice. I don't want that to be misinterpreted at all. However, when someone is feeling hopeless, helpless, they can't function in their environment, they can't take care of their kids, they can't go to work, if you can help them function better and ease that anxiety from vestibular, from the cervicogenic pain, from the whiplash, that all amounts to increasing or decreasing that depressive episode. Okay? So I don't want to get that twisted, but I really think that we can help here. Now there's some carryover here. Dr. John Leddy out of Buffalo is a fantastic physician. If you get a chance to read his work, I really highly recommend it. He correlated here, he has a lot of heart rate variability in concussion, that if you have a cervical vestibular injury and post-concussion syndrome, well, those are the same. Okay? There's a lot of carryover. So you really have to put your detective hats on and look at what you're looking at. Okay? So when dealing with these patients, it's a lot of 2 steps forward, 3 steps back, 4 steps forward, 10 steps back. Okay? There's a lot of milestones, a lot of coping, there's a lot of emotional episodes that can happen here. So really, as a clinician, just be as patient as you can and walk these patients through and be confident that they are going to be okay. And that is one of the biggest things that you can do for a concussion patient. So let's talk post-concussive syndrome. Okay?
Girls soccer players report concussions more often than boys soccer players. Same as basketball. And they also seem to recover more slowly than boys. So this was not just a boys football injury.
Really hard hitter in the game, I would see stars. I've seen a lot of stars. I remember when I told my parents that I was retiring in 2004 because of my post-concussion syndrome, they were actually angry and disappointed a little bit in me and that I wanted to retire. I think they felt like I was just quitting. I would rather them think that than to really know the truth and what's behind it. They know about my headaches, they know obviously about all the medications that I've been on to prevent them, but I don't think they really know how much it interrupts with my daily life. I always keep my GPS on. I'll be driving around the roads I know by heart and forget where I am. Had to stutter for a little bit.
Okay. So the worst thing you can tell a concussion patient is you look good. Okay? They don't look any different, but their perception of themselves is completely skewed. Okay? And it's so complicated because they feel completely different. They look in the mirror and they look fine. Everyone else looks at them and they look like they're saying themselves. And then you have something like this. So this is a text message I got from a friend of mine. And the dude is, it's not people. So he goes, dude, all that stuff. He's like, the facial pressure is annoying. I felt like I was tripping on acid for 3 months. Migraines sometimes, forehead pressure. I feel really dumb and frustrated and almost don't want to talk to people because it's too much effort sometimes. Okay? These patients are incredibly frustrated and they often become helpless and hopeless. Okay? Dr. Taylor is a Harvard researcher. She actually had a stroke. In 2008, she gave a TED Talk lecture. It was one of the top 10 TED Talks in history. I think it was like 40 million views. And I thought this was really appropriate. This is really how these folks feel. I was no longer the choreographer of my life. Okay? She was a brain researcher at Harvard, and she had a stroke. And that's pretty powerful. So let's talk a case. So, 29-year-old female, motor vehicle accident, fender bender, pretty benign. Airbags didn't go off, no damage to the car. Stopped at a red light. She was plugging in her iPhone, and she got hit from the back. Rear-ended, popped up, She's from New York. She was like, come on. She's like, you gotta be kidding. Gets out of the car, immediately dizzy and falls over, grabs onto the top of the car. She's like, okay, something's wrong. Okay. Goes to the emergency room, gets a CAT scan, negative, or unremarkable. She likes to think she's very remarkable, but she's never. And her chief complaint was, I can't see. So this is really important with concussion patients. So 50 to 60% of the brain's pathways are devoted to vision. Not just the simple stuff we learned in neuroanatomy back in the day. Say it again, that's really important. 50 to 60% of brain's pathways are devoted to vision. So vision isn't just about 20/20. Pursuits, circades, divergence, accommodation, so on and so forth. It's not just about 20/20 or acuity. So when she said she couldn't see, her vision was fine. But she actually was diagnosed by 2 different neuro-ophthalmologists with convergence deficiency. This woman's interventions were as follows. She had vestibular physical therapy, orthopedic physical therapy for her head and neck symptoms from the whiplash. She had neuro-ophthalmologists, physical medicine and rehab physicians, vision therapy delivered by an occupational therapist, neuropsychology, and massage therapy for the pain, because she just couldn't get enough therapy, right? You know, the limitations. Meditation, because you think you're going crazy. So we talked about that. Acupuncture, and the list goes on. All right? So anywhere about 10 to 14 hours of therapy a week, okay, for about a year. All right? Fender bender. Looks the same. Really hard to comprehend when you're a bright woman, junior executive of your company of 150, and you've got hit from behind. Now, she has a little bit of post-traumatic amnesia. She doesn't recall she hit her head. She sincerely doesn't think she hit her head, but she can't give a confirmation. So, one of her quotes I thought was pretty powerful. I felt asynchronous with the world and myself. Okay. So this patient was actually me. Okay. So I was hit October 3rd, 2014, 12th Street and 5th Avenue. I was plugging in my iPhone, and I just got railed from behind. Didn't know what happened, it popped up, just like I said. And I was actually going through, because I knew better. I had my MD calculator on my smartphone. I was actually going through like to the CT scan. I knew my Canadian CT head rules. And I was like, I'm not a I still got a CT. So I will tell you though that every single clinician that's ever worked with me did ask to see the CT, which is unfortunate, but we have it. So I'd like to share a little bit of my experience with post-concussion syndrome. So we over-medicalize everything in quote-unquote medicine. If you're going to see a physician, well, what are you really going to end up getting often? It's pharmaceuticals, surgical intervention, or an image. Well, it doesn't really help with this patient population. So first day I saw a neurologist, it was a no-fault case, so I had to go to this no-fault neurologist, with all due respect to him, and he had 5 prescriptions. Told me I was perseverating, and I was like, well, with all due respect, I don't even take Tylenol for a menstrual cramp, and you just gave me 10 bags of Adderall. It's a little crazy. So I go back to this peer review and this evidence-based triangle. I really think that if we add patient experience to this, we can really learn a lot. Okay? What I learned is in a post-concussion support group, over 3,000 folks internationally, about 80% of those folks have been medically mismanaged. They just don't know where to go. They're all over the world. Well, I saw a doctor and it didn't work. Oh, I saw a PT and it didn't work. Well, what didn't work? Was that person familiar with treating concussion? So I think that we're going to learn a lot, and I really hope to bring some texture to medical education with providing this medical experience and bringing my own personal story and others to the game. So here's my symptom checklist. It's all there. From dizziness to headaches to short-term memory loss. Cervicogenic headache. I was easily angered. That was actually really frustrating to be easily angered and knowing that you're easily angered, but you shouldn't be easily angered. Kind of a weird catch-22. I was really pretty passive, not passive, but I was really able to like just let water go off the duck's back before this. And you know, I remember I had like 4 or 5 episodes over the year, and I was like, why the heck am I so angry? You know, it's just over a simple, someone cut the line at the supermarket, or someone took my parking spot. But I could not get over that episode of anger, and I knew I just had to go away. It's really very frustrating. People don't realize this heart rate variability. So I actually couldn't work out. And I'm actually an exercise science major and certified strength and conditioning specialist. You can name all those things. But that was actually the last thing that I got back to, was actually going back to movement. So I was actually kinesiophobic. Total fear avoidance, the whole nine. Every time I did something physical, I got sick for days, hours, days. And those days turned into a day, and then those turned into hours, and then those turned into I could tolerate. But it's really frustrating when you even know what should be happening and it's not happening to your body. So, going back to those interventions from earlier, okay, you have to kind of let this grief cycle happen for these patients. You have to walk them through, and it's a spectrum. It's from acute to chronic. So different things, different milestones are going to hit. So there's no crying in baseball, it's not my favorite line from League of Their Own. But there is a concussion. But there's nothing worse. So I think I tested 94% on executive functioning for my neuropsychology, and I'm a woman who read like 20 medical journals a month. Not normal, I know, my baseline is a little skewed. But I scored 6% on my reading for neuropsych. So when you're looking at things and you just know that you should be able to do things, it's pretty devastating. And then when you become a professional patient, this is all you're doing. You're showing up, you're a good soldier, you're like, I should be getting better, and then you're not. So let your patients cry. You know, it makes you uncomfortable. We talked about getting uncomfortable talking about sex and pelvic floor and things like that earlier. But it's not about you. This patient is going through hell. Okay? Let them have a moment, because they may not be able to have that moment at home. Because why? They look normal. Okay? So let's talk about flooding and neurofatigue real quick. So what are the differences? So flooding, our cognitive reserve, when you're not a brain injury patient, I wasn't going to fill this up, but it's going to get too complicated. So cognitive reserve, probably for a regular day, your water tank's probably filled up here. Normal life stuff, bills, gotta go to work, things like that. Well, when you have a concussion, your cognitive reserve goes way low. Everything's just on high alert, okay? So you really only have this much space to work with in your day. And that's for everything, communication, lights, noises. Everything in your environment is offensive, okay? I looked in my journal and one of my quotes was, I feel like I'm in a war zone all the time. Neurofatigue is when you're here and you're just done. So there's nothing a little bit more scary than when you're going through a neurofatigue, and that was one of my big things at the end of my recovery with heart rate variability and neurofatigue. I actually couldn't do things without getting ridiculously tired. So, I mean, you could have asked me if I wanted peanut butter and jelly, and at that point, if I was spent, I was done. So, no matter what I did, those interventions from before, meditation, the whole nine, you just need a moment. Sometimes you just need a moment. Yeah, all right. It's pretty much how you feel sometimes, and you kind of just have to let it happen. So I'm going to take you through just a couple things before I wrap this up. So I had a couple of scary days, and so I actually really wasn't too familiar with orthodoxia until it happened to me. So I was at mission therapy, and it was a real basic day. We just opened up a regular piece of paper, and I had really big problems with contrast. So white paper, black letters. Not happening for Jessica Schwartz. So when the words move on paper, and you know you've done no illicit drugs, it's pretty petrifying. Okay? So I spent about 9 months in vision therapy as part of my professional patient. And I had a lot of trouble with complex visual things, okay? Now, I don't know if you can see up here, this matrix box that I was playing with for 9 months. One of my worst days, and my occupational therapist doesn't know this, and she'll probably watch this and say, oh man. But she walked away, and we did this, and it was super hard, and I got this crazy headache, and I got this focal pain, my eyeball was hurting. I'm like, what is going on? These are blocks. I used to read journal articles, come on, give me a break. And that said, these are the little things that catch up to you, and you feel like, oh. So this box said, matrix for ages 1 to 3. Yeah, that sucked. So I played with blocks for 9 months. I was a professional block builder. Okay, I might see John for some assistance in my form. And then I kind of graduated with some of this, and we did everything from prone to quadrupeds, just getting my head associated with my body. I didn't have the body on head, head on body, the whole vestibular nine. Okay? So February 3rd. February 3rd happened, and it was my 4-month anniversary. People kind of remember their dates. I had a really good vestibular day, really good. And my vestibular therapist was like, yes, let's try something new. I was like, yes. I like something competitive, let's do it. Something new. He's like, I want you to walk 6 steps, close your eyes for 1, open them, and walk 6 steps. Well, the length of the hallway and my big pause allowed me to do that 3 times. Okay? Turned around, I looked at him, and he looked like he saw a ghost. Like a ghost. I'm like, what's the matter? So what happens is you actually don't know how you feel until later. So another thing, when you ask a concussion patient how you feel, they could feel different every like 5 to 10 seconds, or it may not hit them until like later. Well, I might have turned green real quick, and I didn't know that, but I didn't feel sick until about 5 or 10 minutes later. Well, occupational therapy was right up, you saw my schedule, so he was like, I'm going to take you to OT. I was like, it's a floor. I'm like, I did my residency at NYU. I know this place. He's like, I'm going to take you to OT. It's OT, occupational therapy. She's like, what the heck did you do to her? And I have no idea. I'm like, what's going on? I'm like, trying to look for a mirror. So I got so sick this day, and I have to tell you that one of the greatest thing that happened to me was during a session. She's like, Jess, she's like, just lay down, lay down in the dark room. And she put a weighted vest on me. I got so sick, I had no idea which way was up. I guess I was gray, and I kind of felt drunk. And she put a weighted vest, and she literally just held my hand for the 40-minute session. And she's like, you're gonna be fine. She just reassured me. And it was probably one of the most profound therapy sessions I had in that year. So April 18th, was the day that I thought I lost what I wanted to be when I grew up. I was 15, I knew I wanted to be a PT. April 18th was, I was supposed to go back to work May 5th, Cinco de Mayo. Always a good party on Cinco de Mayo. All right, and my short-term disability, and that was the day that I actually realized that I was not going to be ready to go back to work. And my clinicians needed me to see that, but completely out-of-network provider before this, you're in your partner, knew a little bit about business. I was so disappointed in myself as a clinician. I set myself up to go back to work based off of insurance parameters. So disappointed. So I wasn't ready clinically. So my neuro-ophthalmologist, this is probably the best thing that happened to me. She said, Jess, that you have to be kind to yourself. That was such an important feedback that I got during this. So for me personally, I ended up coping, and you have to figure out, everyone needs to cope differently. Some folks have kids, folks have people to take care of, jobs that they can't be off of for 6 months. So I did it with humor. The Just Fix My Melon is my favorite. So that goes to the Humans of New York credit, not my photography. But then I also, we're physical therapists, we like to help people. So I actually ended up creating this blog, and there's kind of a live story on it. Ironically, the next story I'm going to publish this week is actually a physical therapist. So that'll go up towards the end of this week. She's a PT who's had post-Concussion Syndrome since 1999. So it's going to be a pretty neat story. So it's a safe space for people to share their stories. But I really want clinicians to really draw their attention to this site, because they're going to learn from hearing the patients talk about their stories. Okay, so this is an 18-year-old girl, very, very, very in tune with herself. Okay, and she got hit in the head playing soccer with her brothers. Just to pick up two in the back. And she said some pretty profound things here. She's like, I obviously don't wear a cast on my brain like a person would if they broke their leg. This is one of the most frustrating parts of everything. People just don't understand. She looks normal. So going back, closing up shop. Healthcare and teams. We know that individual competence doesn't equal good healthcare. Well, what if you have one of these patients in your line of sight? You have to screen and look for the deficits. You have to document the deficits. Okay? They're undergoing this maze of disconnected healthcare episodes. So they might be seeing the right people, but the right people might not be looking for what they should be looking for. Okay? So I really believe in teamwork. So these were my superheroes. And you know, these are the guys that got me back. So I really have to say thank you to my team at NYU who put up with me for a good year. So in terms of my role, what do I see myself doing for the rest of my career? Well, that's Chris Nowinski. He wrote Head Games. He's the Harvard football player that wrote Head Games and was produced it. And that's Ben Utrecht. He's the American Academy of Neurology Concussion national spokesperson. Well, in March of this year, I actually became one of our new national spokeswomen for the American Physical Therapy Association. So, with that being said, that was just a bonus. They didn't even know that it is. I was like, all right, right on. I was like, now I have a platform. But I really believe that Chris and Ben do a really good job educating athletes, educating coaches, educating other post-concussive survivors about their history, about what's been going on. Well, my role is I want to educate doctors. I want to educate clinicians because we need to do better for this patient population. They're being so mismanaged and they're so helpless and hopeless. And yes, you're going to have malingering folks. You're going to have it happens all the time. But that mother of four who hit her head, Cindy, the soccer player from earlier, Harley, you know, she looks great. She's going to drive with her GPS on. All for what? Olympic gold medal, World Cup champion. Is it worth it? We need to educate each other. So today I'm actually really excited to say, John Child put a lot of gusto into me here. So we're actually going to be launching, and I'm actually thrilled to say this, we're going to be launching, I believe, what's going to be the first post-professional concussion education certificate through EIN. So what does that mean? So we're going to get to this all together. I hope to facilitate collective confidence across the healthcare continuum in order to better identify, treat, and manage the concussion patient along the entire symptom of presentation. So this is not going to be a sports concussion certificate program, okay? You're going to have the option to specialize. But there's going to be everything from pediatrics, okay? 21% of the population in 2030 is going to be 17 and under, okay? 22% of the population is going to be 65 and over. So you'll have the opportunity to specialize in geriatrics. These people need to move, okay? Trauma, domestic abuse, and the veteran, and sports. So what's going to happen here is hired a bunch of faculty, and actually all are my first choice, internationally. It's awesome. So we have everyone from the emergency physician, the neuropsychologist, the speech and language pathologist, the cervicogenic PT, the stimular PT, what else do we have? Stimular PT, it's the concussion moments, just bear with me here. Session PTs, speech, OT, everyone's in it. Oh, and athletic training, okay? So we've got everyone in. So my goal is to have everyone educate each other about what they can do for this patient. Because once we understand what each of us